An international speaker in anti-aging, regenerative, and functional medicine. And he's been lecturing worldwide, including Indonesia, Bangkok, Malaysia, India, China, and a part of Europe. Correct me if I'm wrong, Dr. Kapur. And this is only the shortest part of his very long CV. And this morning, he will share the knowledge he knows best in how to do hormone testing, starting from the collection to interpretation. So I think everyone, please welcome Dr. Sanjay Kapur. Dr. Kapur, I'm handing you the floor. Thank you.
All right. Well, thank you. Thank you, Dr. Rani, for the wonderful introduction. and it's not too early for me because it's evening time here, 5:15 p.m. And it's too early for you guys on the other side of the planet that you have to wake up so early to listen to my 5-hour lecture now. Well, don't worry, it's not it's not going to be 5 hours. I was told that I have 6 hours, but I thought I will keep it to 5 hours. But no, don't worry. I'm not going to spoil your weekend. So let me right away begin this talk. Some slides that I have to share with you. And feel free to maybe stop me in between if you have any questions, or if you want to keep the questions till the end, that's fine too. But I don't mind if you want to stop me in the middle and ask any questions. So let me put my screen up here. All right. So we'll talk about mainly on the hormone testing part. I know there have been many speakers who have talked about hormones already, and I'm glad that you have a basic concept about all the hormones and why we need to balance these hormones. So anyways, I'm sitting here in Portland, Oregon. Not sure how many of you have been to Portland, but it's a beautiful city. I know it has not been in the news for the right reasons lately, but we do have a beautiful fall season here that we just finished. So trust me, these are the true colors that we see here during the fall season, which we saw last month. So it's not too bad. And this is something that is an icon of Oregon, the Mount Hood, which stays covered with snow all year long. And so we can brag about having some beautiful natural settings here in Oregon. And this is my lab here in Portland, the building from outside. Let me take you inside the lab. So this is just a part of the lab that I wanted to share with you what it looks like. I know you guys spend most of the time looking at the patients, and I spend most of my time looking at these machines inside the lab. And I feel so proud to share with you that we are one of the world's leading hormone testing lab. And we have a wonderful team of people working in this lab to do those hormone testing accurate and perfect. And this is my office where I have been stuck for last 8 months. And right now also I'm sitting in this office. I wish to be somewhere else rather than getting stuck in my office. Are you able to see my slides?
Not yet, Doc.
Oh, really?
Yeah.
I thought, let me share with you. Let me go back. I thought I could show my slides to you.
Yes.
Looks like, are you not able to see my screen?
No, I think you take it down previously. So
Oh,
yes.
I'm so sorry. I thought you were able to see all those slides.
Mm,
Let me see, what did I do? Okay. Give me 1 second while
Yes.
while I
Yes.
figure this out.
That's okay, Doc. That's okay.
Can you see my screen now?
No, Doc, not yet.
Not yet?
Yes.
What happened?
Have you tried to open the file?
Yes.
And then just click on the share screen button, Doc, on the below on your laptop or computer screen. Are you using Mac, Doc?
No, it's a Windows.
Okay. Just click on the button, on the share screen button, at the green button below. Can you see?
I'm trying to find out where is that green button.
Oh, just hands your mouse down on the below on the Zoom. Scroll your mouse on the lower third part.
I can't see it.
It's usually on the same side where you can push the mute button and the video button. Can you see it now?
All right.
Yes.
Can you see it now?
Yes, Doc, we can see it now.
Okay. All right. So I guess you missed the pictures that I showed earlier. Let me go back and show you those pictures that you missed. All right. So I was saying that I'm sitting in Portland, so I already gave you all that background. And so this is the fall that I was talking about. Now you can see these, right?
Yes, Doc, we can see you, Doc.
Okay, perfect. Because I'm so passionate about the fall season here in Oregon. So I wanted to show you these beautiful pictures because these days people are not talking very nice about Portland because of the riots. but we are in a very beautiful place. And so this is the lab that I was talking about. This is my lab, um, and this is the inside of the lab, which I wanted to share with you and show you where most of my day goes. And this is the office where I told you I was stuck for last almost 8 months since COVID hit. And I'm still sitting in this office talking with all of you. And like, as I said, I would have preferred to be on this beach talking about the functional medicine and all kinds of hormone testing that we are going to talk about today. But as I said, because of COVID, everything has changed. We are kind of into a learning to live a new life, but at the same time, let's not forget what we have always been talking about whenever we talk about the functional medicine, right? You might have seen this slide in many, many conferences, and all of you have heard this many, many times, that how important it is to focus on underlying causes of the diseases. The diseases are basically the symptoms that we see only after all of the underlying mechanisms and underlying causes. Like, since we are focusing on hormones today, it's the hormone imbalances that are extremely important to understand before we can understand the disease and before you can come up with any kind of a treatment plan, right? And so that's what we are trying to focus today. It doesn't matter what you call it, whether you call it Western medicine or functional medicine or Chinese or whatever you feel like. So it's all basically encompassed under integrative medicine. And that's how we should talk about it. That's how we should look at it with a holistic approach. We should talk about wellness care rather than sick care. See, that's what I keep telling everybody, that we use the word healthcare, but there is nothing like healthcare, right? Because of the reason that we are so distracted by the conventional medicine and the concept that we have been learning from conventional medicine. That has to change. This is one particular data that I wanted to present to you from back in 2010. At that time, we thought that by 2020, less than 20 million people will die of infectious disease, and there will be more than 50 million people that will die of chronic disease. Although here in 2020, yes, more people are dying from the infectious disease, COVID, but still, there will be many, many more people dying of chronic illnesses. And so let's not forget about that, even though, yes, our focus is on COVID right now, but we just cannot forget the whole underlying mechanisms causing different kinds of other diseases, other problems. Because we know that, as you can see here, globally, $2 trillion are lost in productivity every year because of the chronic illnesses, right? And just in USA, it's almost like $750 billion being spent on just heart disease and diabetes. So it's serious. See, it's interesting when I say diseases don't exist. Yeah, and that's true. Diseases don't exist. When we are talking about chronic illnesses, we use these word disease all the time. But again, I would say diseases don't exist. We create those diseases, right? We talk about these food, the lifestyle, and whatever we basically do, interact with the environment, all these things. So basically, we create those diseases. They don't exist by themselves, and so that is kind of a functional approach, a functional medicine approach, that I'm sure you've heard many speakers talking about what is functional medicine. So basically, it has been summarized as it's a systems biology-based approach to individualized medicine that focuses on underlying causes of disease. So let's focus on the underlying causes of the disease, and let's focus on hormone imbalance as of today. That our focus of this next 1 hour or so will be. So basically, it's time for a paradigm shift, because conventional medicine so far, and still there is a 50-50 split between conventional medicine doctors and functional medicine doctors, where we really need to bring everybody's attention to the fact that it's time for a paradigm shift. It's time to think something out of the box to change the way we have practiced medicine so far. And I'm sure you're all going to agree with me that the way we have practiced medicine so far, it has not worked, and it's not working. And that's why you see these numbers growing in terms of chronic illnesses, right? And if we did not stop right now, as of today, and did not learn properly how to fix the underlying mechanisms of these diseases, well, there will be no change. People will still die, and so-called sick care model will continue to operate. So that's the idea that we need to kind of change. So how do we change that? See, we know that there is a person, and this person has a genome, right? We know that the genes have been sequenced, that the genome has been sequenced, and this how the person's genome interacts with lifestyle and environment, that determines the final end game. And basically, when there is an interaction between the lifestyle and environment with the genome of an individual, there are all kinds of imbalances in the overall network of biological systems, right? And that you're all familiar with. And that eventually, that ultimately causes symptoms. So whatever way we interact with our environment determines what symptoms or so-called disease will finally appear in an individual's body. So it's not only about what is the problem, it is also about why it is causing. What are the causes? Why those are the causes? That is what we need to understand very clearly. Now that we are, well, this is a big word here, coronavirus. I know all of you, all of us, whole world has been thinking about COVID now. And interestingly and sadly, COVID is not going to go away anytime soon, even if the vaccine will be here soon. Now, when I say it will not be, it will be here for a while, is because now once the COVID is here, it is going to interact with our physiology in many different ways. And these are some of the articles that some of our docs have written, and these have been posted on our website. So whenever you get a chance, go to our website, iumetrics.com, where you can read all of these articles where we have put together the interactions between COVID-19 and different kinds of hormonal systems. So like, as you can see, there are studies that have shown that COVID-19 interacts with, well, basically affects the adrenal system and interacts with cortisol, basically. The cortisol, there was some recent studies showing that there is an increased cortisol in these COVID-19 infected patients, and that could lead to extreme depression of the immune system that leads to mortality. And then there are many other interactions between the androgens and COVID-19 So please feel free to read these articles on the website. Then this one says hormonal imbalance and why testing is important. And we will talk a little bit more in detail that why testing is important, not only for COVID-19, but pretty much for everything that we must learn about. COVID-19 has been shown to have effect on the thyroids as well, on the heart disease, diabetes. So basically, and that's the reason I say that COVID-19 is not going to go away anytime soon, because once it has infected people, once it's there in the bodies, it is going to change many, many systems that we will have to study more, learn more about those. And to learn all of these interactions, the newer concepts now because of COVID, and of course, because of existing issues that we have been dealing with until now, what is more important? Testing. Without testing, you cannot just guess. You cannot just look at the patient and just guess what their hormone levels are, right? And so that's where the testing becomes extremely, extremely important. And that is exactly what we are going to talk about today. That why testing is important. Well, we touched a little bit on that, but how testing is done. I know most of you spend most of your day in looking at the patients and talking to the patients, but and all of you, well, all of the docs have been educated to basically test blood when you were in your medical schools. It was only when you came out of the med schools, you knew that whatever biomarkers have to be tested, they can be tested using the blood. That phlebotomist draws your blood from the venipuncture, and then you test whatever you want to test. But now the lab testing concepts, especially related to hormones, have been changed significantly. And when I say the concepts have been changed, it's because of the studies, because of the research that has been done, where in a number of studies where different body fluids have been used to test different hormones in different conditions. And that's exactly what I'm going to talk about today. So we know that there is usually blood that we use to test most of these biomarkers. Then there is urine and saliva. I'm sure some of you might have used saliva, but if not, then this lecture is extremely important for you to understand why saliva in some cases and why blood in some cases and why urine in some cases. Well, we will not talk about urine testing today because urine testing is a whole different concept. It's a whole different lecture. So maybe some other day we can talk about the urine testing, because urine is mainly used for metabolites. It's not really a perfect body fluid for the hormone molecules, like full hormone molecules. Whereas blood and saliva is what you should understand today for most of the conditions, for most of the situations that you face when you're treating your patients. So here, this particular slide shows you kind of a brief comparison and shows you some limitations of hormone testing in different body fluids. So as you can see, in saliva, we can test most of these hormones like estradiol, progesterone, testosterone, DHEA or DHEA sulfate, and cortisol. But you cannot test other hormones like FSH, LH, or thyroid hormones, and some other peptides. Then in blood, yes, you can test almost everything But again, as we go deeper into this lecture, you will understand that in some cases, you should not be using blood, especially when your patients are supplementing with hormones. And when I say supplementing with hormones, especially when you're supplementing with topical hormones. And I will talk more details about that concept, that why you should be using blood from veins, or when, or why you should be using saliva. And urine, as I said, yes, you can measure all of these hormone metabolites, but if you want to study about the hormone molecules as such, then urine is probably not a best option. And again, when your patients are supplementing with topical hormones, in that case also urine is not a good option. You should be measuring in saliva or the capillary blood. And I will talk to you about the capillary blood, the details on that as well. So see this slide especially, you should all have it on your desk, in your office, in your clinic, on the wall somewhere, because this slide is basically the summary of today's lecture. And this slide, if you can understand and keep it as a reference in front of you while you're deciding whether to use saliva or whether to use blood or dried blood or urine, whatever. This is going to be extremely, extremely helpful. So let me explain this to you step by step, because otherwise it looks very busy slide. But let me break it down and try to simplify it for you. So whenever you're using endogenous steroids, endogenous hormones, whenever you're measuring endogenous or basal levels of these hormones, it does not matter what you use. You can use serum or saliva or urine or DBS. DBS is dried blood spot. Now, dried blood spot is when you collect your blood by pricking your finger, and you can put a few drops of blood on a piece of paper. It dries. It's called dried blood spot. And that card with the blood spot on it, that can be mailed. So we receive samples from basically all over the planet in the form of dried blood spot. So that is called DBS. So to measure endogenous hormones, you can use any of these body fluids, absolutely no problem. But when you're using oral supplements, oral hormones, especially steroids, yes, you can use the serum, but if you pay attention to this, number one, there is a possibility of overestimation of the hormones. Why there is a possibility of overestimation? Because of there are some metabolites that can interfere with the immunoassays methods that the labs use. So it's always better if the lab is using the LCMS or the GCMS or any other better, more sensitive method. Then in that case, you might risk using the serum for oral steroid testing. You can use saliva, but again, there is a possibility of overestimation, because when you're using oral hormones and you're collecting saliva and you're not careful, then you might contaminate the sample, and the lab might overestimate the sample, the hormone levels. You can use urine, and again, the same issue with urine is that many of the metabolites that might interfere with the assays. So it depends what kind of testing, what kind of technology the lab is using to test your samples, your patient samples. So make sure you're using the right lab, which understands these concepts very well, and so that they know that in this particular patient or this particular sample, they have to use the right body fluid and they have to use the right method to test. So it's extremely, extremely important when you choose a lab, ask these right questions. So DBS is the, again, as I said, capillary blood can be easily used and should be used because there is less chances of contamination when your patient is taking the oral steroids. And I will explain to you in more detail in this lecture that why DBS and what is it and why, what are the advantages and disadvantages of each of these methods. So let's talk about topical steroids. So this is extremely, extremely important point to understand that when you're using topical hormones, creams or gels, then you just cannot use the venous blood. You cannot use the serum. That is the conventional way. And I will share with you some of the slides which will basically surprise you. And that will be an aha moment when you will say, oh, okay, that's what it makes sense. And that's the reason I cannot use the venous blood when I'm using topical hormones to supplement my patients. So why you cannot use the serum? Again, hormone levels are not reflective of tissue uptake. So you want to know how much hormone is inside the tissue, inside the cells. It does not matter how much hormone is circulating in the body, in the blood, because until and unless the tissue gets the hormone it needs to function, it's of no use, right? Just like diabetes patients, there's so much of sugar in their blood circulating in the body, but their cells are starving. They don't have any sugar. That's the reason they die, right? So same way, it does not matter how much hormone is circulating in the blood. We want to know how much is actually bioavailable fraction, which is going to the tissues, which is going inside the tissues. So that's the most important thing to remember. So in case of topical steroids, you cannot measure the bioavailable fraction. And I will explain to you more on that concept. Saliva is the best option in this case. But again, you have to use the right lab that knows how to adjust the ranges properly to be able to make the right interpretation for whatever hormones you're supplementing with and how to basically interpret those test results. So, but as long as the lab is smart, as long as you have access to a good lab, then that's all you need. So urine, again, same problem. When you're using topical hormones, urine basically gives you kind of an underestimation. Hormone levels are not reflective of tissue uptake, because in the urine, you're basically measuring the metabolites that are going out of the body. They are not really inside the tissue, or they don't reflect the levels inside the tissue, which again, it's kind of, it has been seen that most of these metabolites have not been shown to correlate with clinical symptoms. So you have, whenever you're testing hormones, you have to make sure that there is a proper correlation with the clinical symptoms. You always have to make sure that you're not treating the numbers that you get from the lab. At the end of the day, yes, it does matter. The lab results are important, but at the same time, you are the one who is treating the patient. And you're the one who is talking to the patient, looking at the patient. So you have to make a perfectly balanced decision based upon the patient's condition and the results that you get from the lab, right? So that's extremely, extremely important. But at the same time, you have to have a trustworthy lab that knows what exactly they are doing. So they should be able to give you a good test result so that you can treat your patients right. And then finally, you can use the DBS, the dried blood spot, which is capillary blood. But again, you have to make sure that the fingertips of the patient are not contaminated, because sometimes what happens is that the patients use the same fingers, same hands to apply hormones on their body, the creams and gels, and they forget that even if they wash it, rinse it with water, they forget that there is too much of hormone on the fingers. So when you're instructing your patients to do the topical hormones and collect their DBS samples, you have to instruct them properly. You have to tell them what they should be careful about. And these are all the instructions that the lab should provide in their collection instruction manuals. And we do have all those proper guidelines for sample collection. And I'm more than happy to share with you all of those guidelines. And I think those are available on our website as well. So don't forget to log on to the website, and there's a lot of information there. But anytime, feel free to send me an email, contact me if you have any questions regarding hormone testing. So next one is the vaginal steroids. So vaginal steroids is similar to topical applications. So basically it is the topical application, right? So same thing, you cannot use the serum. When I say serum, it's the venous blood draw, which is the conventional way that if the phlebotomist draws blood from the vein, separates the serum. So that's the serum that I'm talking about here. So you cannot use the serum. You can use saliva, and you can use the DBS for the same reasons that I just explained. Then troche is similar to oral because basically your troche means sublingual. You're using the hormone under your tongue. And so in that case, yes, you can use the serum, absolutely no problem, but you cannot use saliva, right? Because there could be a direct contamination of oral mucosa, and saliva could be contaminated with very, very high dose of the hormone. So you should not be using saliva in that case. You should not be using urine, again, because the urine does not reflect the tissue uptake of the hormones when you're doing the troche. DBS, absolutely, you can use it. It's a great option. Especially when your patients don't want to go to a lab to get their blood drawn. Many people, they don't comply with your requests to get to the lab and get their blood drawn. People are very lazy these days. And of course, with COVID, you cannot expect your patients to go to the lab and get their lab work done. So it's a great option that you can just send them a card, a kit, a small kit at home by mail, and they can collect their sample at home in their own privacy, and they can mail that sample to the lab. So that's very simple. And then the next one is pellets. If you're using pellets, then yes, you can basically use any of these body fluids to do the testing part. Anyways, I think I spent a fair amount of time on this slide, but like as I said, keep this slide in front of you in your clinic, on your desk, put it on the wall in front of wherever you sit, so that you keep looking at it and you have an idea what kind of body fluids to use at what time. Do we have any questions so far, or is it okay? Is everybody still awake?
You're here, Doc.
Okay, good. I just want to make sure that I'm not the only one in this room now.
No.
See,
No.
I love being on the podium, and when I can see the audience at all times. So that's the kind of presentations I like, because I don't fall asleep. But in these Zoom meetings, I have to make sure that everybody is still there and everybody is awake.
We're here.
We're all here. Thank
Okay,
you.
perfect. So just hang in there. Let's move on to each of these testing methods one by one. And so let's talk about hormone testing in venipuncture, serum or plasma. And we'll talk about what are the good points, what are the bad points of using each of these body fluids for testing. So serum, what are the good points? A wide range of hormone tests are available because the labs have been running on these methodologies for a long, long time. Automated FDA approved methodologies have been available. Here in the US, most of the serum testing is covered by insurance companies. I don't know much about Malaysia and Indonesia and all those places there, that how the insurance companies work. So familiarity with levels and ranges, because everybody was taught in medical schools and during their practice about serum. And so that's why everybody's familiar with those ranges. So you don't really have to redesign or rethink or retrain your minds to look at different ranges for other body fluids. What are the bad points? Well, invasive, sharp needle in the arm, which people don't like it. It's stressful, inconvenient to patient. And as I was saying, that people have to go actually out of their home, get an appointment at the lab. And so it requires driving to the blood draw station. Phlebotomist is required, so you can't just stick in the syringe in by yourself and draw your blood yourself. So processing of specimen is required. You have to centrifuge the sample and keep the blood in cold packs if you have to ship it or if you have to store it. So these are some of the disadvantages of serum testing. The major disadvantage of serum testing is that the normal ranges are extremely wide. Like the normal ranges are really broad, and which are actually geared for disease rather than failing health. Now, what does that mean? That if a patient is for anything, let's take an example for insulin. The range, so-called normal range, is so broad, from, let's say, from 3 to 15, that if the patient is at 4, it's normal. If the patient is at 14, it's still normal. But we don't really pay much attention to if that patient gets tested again and again, if there is going to be a trend change in the insulin levels. We don't normally pay that attention. We just think that, okay, the number is within the normal range, so it's all good. And that's the problem I have with the conventional ranges that have been well established for the last 50 years. And we are still following those ranges. And I think it is time that we need to tighten those ranges so that we don't wait until the patient gets the disease or the patient gets sick, so that we can catch it on early. So that's one problem I have with these ranges. And difficult to measure multiple times. Like, you cannot ask the patient to collect 3 or 4 samples in one day if you want to test using their serum, regular serum. And your patients are going to hate you if you told them, go to the lab, sit there all day, have a picnic, and tell the phlebotomist to get your sample 5 times a day. They're not going to come back to you ever again if you told them this. especially like why I'm saying multiple samples. Let's say if you want to do cortisol testing. Cortisol is a stress hormone. As such, if a patient collects their sample even once by phlebotomy, regular phlebotomy, they're already stressed. And if they have to do the same process 4 times a day, guess what? You're not going to get the normal levels, the normal baseline levels for cortisol. So that's definitely not a good idea to use serum for cortisol and for many other hormones. And we'll talk in detail about that. So usually measures total and not bioavailable fraction of hormone in bloodstream. See, this is extremely important. In blood, in the venous blood, when you're testing a hormone level, it's giving you a measure of what or how much is the total hormone circulating in blood. It does not tell you how much is the free form of the hormone, which is not bound to the binding protein. See, when the hormone is bound to the binding proteins, it cannot enter your cells. It cannot enter the tissues. So it's totally useless. So to enter inside the cells, the hormone molecule has to unbind from the binding proteins. So when it has to unbind, means it has to be a free fraction. Now this free fraction is called the bioavailable fraction. Now this bioavailable fraction is what you need to know if you want to have a good treatment plan. And again, if you're measuring in the venous blood, it gives you only the total hormone fraction. But if you're measuring in saliva, saliva contains all of the free form of hormone. So, which gives you the accurate measurement of what is bioavailable, which is available to the tissues, which correlates much better with clinical symptoms as well. And let's see some more slides where you will get a better understanding of what I'm talking right now. And so this serum methods, when you're testing hormones in serum, it's not a valid method for measuring hormones delivered topically. As I was explaining to you in that first table, the summary of all of these body fluids, when you measure a hormone using the venous blood, especially in those patients when you're monitoring or when you're supplementing with topical creams or gels, the total hormone measured is not reflective of what is available in the tissues or what is the bioavailable fraction. And I will show you in one of the data slides that I have for you, which will explain to you that what is the difference in the hormone levels after topical supplementations when you test the same sample, same person, saliva or the blood or the urine and the venous blood. So that's a very interesting data that I'm sure you're going to love that. So anyways, those were the disadvantages of serum testing. And another one that I just want to share this with you, serum progesterone following oral progesterone delivery. So what happens is that there is a problem with high level of progesterone metabolites that are bioinert, but cross-react with antibodies used in immunoassays. Now, what does that mean? I know this is kind of a technical language for the lab folks, but to make it understandable in a simple language, let me share this with you, this particular slide. So this slide shows you the hormone levels measured by 2 different methods in a lab. After the patient took 100 milligram of progesterone, oral administration of progesterone. So the reason I want to show you this slide is how important it is, number one, to use the good lab who understands the difference between using these different methods, because different labs use different methods for testing, especially these hormones. Some use immunoassays, some use LCMS. LCMS is liquid chromatography mass spectrometry assay. And immunoassay uses antigen antibody reactions. So anyways, I'm not going to give you a lecture on the lab technologies, but just trying to give you a little clearer understanding of why these testing methods are important and why a good lab is important. So that you can ask educated questions to whatever lab you're using at this time. So in this one, as you can see, this x-axis here shows time after administration of the hormone. And on this y-axis, you can see the concentration in terms of nanograms per ml of progesterone. So if the lab used immunoassay method, look at the levels that you will get if the lab was using immunoassay. And if tested by LCMS, look at where these levels are. Now, the reason for these false high results is because of some of the metabolites of these hormones. When you're measuring in the venous blood, they interact with the antibodies that the labs use for immunoassays. And that gives you the false high results. So this is another disadvantage of using the venous blood, and especially combined with the immunoassays. All right, let me move forward and not confuse you in the lab technologies. Let's talk a little bit about hormone testing in saliva and what are the good and bad points of using salivary hormone testing. Very simple and easy to collect, stress-free. You just have to spit in the tube and that's it. No phlebotomist, no venipuncture, no going to the lab. You can collect your own saliva at home and your patients basically fall in love with you when you give them such easy options to get tested. Non-invasive, no needles, more convenient for you as well as your patient. As I said, they are going to love you if you gave them the option of saliva testing. Some more advantages: optimized for collection any time of the day or month, any place, right? You just have to spit in the tube. Well, it's good that you're not spitting in the tube while you're flying in the plane. People sitting next to you are not going to like it. But I have collected my sample in the plane also because I was supposed to collect my saliva at some particular time for a study that I was doing in the lab. But don't ask your patients to do that when they're flying in the plane. They can collect sample when they're sitting by the beach. That's okay. So it's fun. Anyways, no special processing or like no ice packs or centrifugation required, because samples, these hormone molecules are extremely stable for almost 30 days. So there is no requirement of ice packs. Just like for blood, you need to have the liquid blood get to the lab within 8 to 12 hours. So that's not a problem with saliva. Hormones are very, very stable. In convenient shipment by regular US mail, and of course anywhere, any other mail, it's very convenient. Now, what are the bad points of using saliva? Restricted to only steroid hormones. You cannot measure any thyroid hormones or any other peptides like LH or FSH. Saliva is the best option for steroid hormones. Steroid hormones means estradiol, progesterone, testosterone, DHEA, cortisol. As long as you want to measure these hormones, saliva is the best. And I will show you some data which will convince you why saliva is the best. Technically more challenging, that's for the lab. not for you, because the methods that we have to use in the lab to test these hormones in saliva, we need very, very sensitive technologies to measure these hormones, especially estrogens. DHA and cortisol is fine, but estrogen, progesterone, to some extent testosterone, these are in very low concentrations in saliva. So we have to use very highly sensitive methods to use them, to test them. And food and beverages sometimes can be the problem, especially when your patient is eating a hot dog and collecting saliva at the same time. And we see those hot dogs when we receive those saliva tubes, and my technicians, they open those tubes, they can find those hot dogs there. Bad idea. So you have to provide proper instructions to your patients that please don't eat or drink anything when you're collecting your saliva samples. Sublingual use of hormones leads to spurious high test results. Same thing, if you're using food in your mouth or using any hormones in your mouth, not a good idea to collect sample at that time. Food contamination or hormone contamination. Then there are some people who cannot produce enough saliva. So for them, probably it's not a good idea to ask them to use saliva. So anyways, let's take a look at this particular slide, which will give you an idea on what to expect when you're testing saliva and what is the kind of a difference between salivary sex hormones and the serum hormones in terms of the total level, hormone level. So when you're measuring the serum hormone, as I shared with you, you're measuring the total hormone. And when you're measuring the salivary hormones, as you can see here, estradiol, progesterone, or testosterone, what you should expect is that the salivary sex hormone levels are approximately 1 to 3% of the serum hormones. So the total level, the hormone level is different from the blood as well as compared to saliva. As you can see, the estradiol, in terms of estradiol, average premenopausal serum has about 100 micrograms per ml of estradiol. And average premenopausal saliva is approximately 2% of that total, which is about 2 micrograms per ml. And when you look at the actual serum estradiol range, as you can see, it's between 43 and 180 picograms per ml. Again, these ranges are different from different labs, but in general, these are the levels that you see in the serum when you're looking for estradiol. Calculated saliva range should be approximately 2%, which is 0.9 to 3.6 picograms per ml. And when we see actually in the lab by testing, this is a range that we get for saliva. So why I'm sharing this with you is that you have to train your mind to look at these smaller numbers when you're measuring saliva, when you're measuring hormones in saliva as compared to blood. Because if you've been testing hormones in blood, you're used to looking at the higher numbers. So that's something that you should keep in mind, that in saliva, it's the free fraction of the hormone, which is approximately 2% of what you see in blood. So this is something that I was telling you, that how you have to be careful in terms of measuring different hormones in the body fluids in saliva. DHEA or DHEA sulfate is absolutely no problem because of high concentrations. Cortisol is also fine, but the problem is with estradiol. Estradiol is the least concentration in saliva, so the lab has to be good enough to be able to use a proper technology to measure estradiol accurately. And that's the reason it's so important to use the right lab and the right technologies. Anyways, so what is the clinical utility of using salivary hormone testing? So we asked some of these questions to ourselves and tried to test them in the lab, do some internal research studies to find out whether saliva hormone results correlate with clinical symptoms and make sure that it's okay to use saliva rather than blood. So do salivary hormone levels show expected relationships with menstrual cycle, especially estradiol and progesterone? We wanted to make sure that we do see the changes, the follicular and the luteal peaks when we use the salivary hormone testing, and I will show you some data on that. We also wanted to see whether age of an individual would change or would reflect the change in the salivary hormone levels, premenopausal versus postmenopausal. Can we differentiate these things in these samples? Whether there is a diurnal pattern that we can see, high morning, low night, especially when you're measuring cortisol, do we see high levels in the morning as compared to night? So we tested that in-house. So, and was there any relationship between symptoms of hormone imbalance, especially when there is deficiency and excess? And then what happens when the patient is supplementing with the hormones? Again, all of these things are extremely important when you're choosing the body fluids. So let's look at this menstrual cycle variation. So what we saw, as you can see here, the top panel shows serum estradiol, and the bottom shows the salivary estradiol. Same patient, but different body fluid. So whether do we see the same pattern? Yes, we do see the same pattern. We see these levels, the peaks, they correlate at the same time, as you can see the days of the cycle. So the peaks are at the same position. Pay attention to the numbers right here on the y-axis. Do you see what is the difference in the numbers in serum versus saliva? This is exactly what I want you to pay attention to, that the numbers that you see, the hormone levels that you see in salivary, in saliva are much lower than what you see in the serum. Much lower means in saliva, as I shared with you, it's about 2% of what you see in the serum. That's the only difference, but otherwise you do see the same pattern. So how the age affects these hormone levels? Does saliva show an accurate assessment of changes as compared to serum? So as you can see here, this is the graph that shows estradiol levels decline dramatically at menopause, as you can see here, about 45 years of age. And this is the data from almost 17,000 women. And as you can see, there is a significant decline here in estradiol levels as you enter the menopause right here. So which shows that saliva does show this pattern. See, this is not a new information, but the new information is that the saliva is a good body fluid to use, and it does show the variations in these hormone levels with age. So that's what I'm trying to show here. Same thing as you can see here, this one shows hormone levels, the total levels of DHEA and cortisol with respect to age. And we all know that the DHEA starts to decline as we age, right? Again, this data is for almost 20,000 people. DHEA declines with age. There is not much change in the cortisol levels. So what does that mean? Here is what you need to pay attention is to the ratio, the cortisol DHEA ratio. Why? Because look at this time here between 40 and 48 years old, during this time, that ratio shifts. That relationship between DHEA and cortisol shifts. And that's when we see the decline in health, overall health. See, the cortisol levels did not change much as we age. But just because the DHEA levels go down, we see all kinds of issues, all kinds of problems related to the shift in this ratio. So again, when you're measuring these hormones, these are the things that you have to pay attention. So it's just a data from normal individuals. So this change in the ratio, the shift in the ratio can occur because of anything, any pathogen or any other condition affecting your patient's health. Let's say for COVID. Well, I have not seen any data yet on the COVID that how does it affect the levels of DHEA. I still have to find more data, or maybe I might have some patient samples, COVID positive patient samples in the lab so that we can test their DHEA and see how things are changing. But there have been studies that COVID has or does significantly affect the cortisol levels. And it increases the cortisol levels significantly to a point where very high cortisol levels depress the immune system. And that's the reason that with people with high cortisol and people with high stress levels, and that's the reason most of those people are dying. And cortisol levels have been correlated with that. What about the diurnal pattern? Do we see the diurnal pattern, especially for cortisol, when we test saliva? So this is not the data from my lab, but some other studies that have shown that, as you can see, the top curve is the cortisol. So this is the morning, noon, evening, and nighttime, and again, next day. So we do see that diurnal pattern of cortisol. So these are all salivary hormone testing, not the blood. So you clearly see that the cortisol is highest in the morning, and then as the day goes by, the cortisol levels drop. And at nighttime, it should be at the lowest. But when you're measuring these in patients who are depressed or patients who have any kind of sleep problems, or even patients with breast cancer, their night cortisol is very, very high. So if you're measuring only morning cortisol, it's, again, you're missing the boat. If you don't test 4 times during the day, you will not be able to get a clear picture. So especially for cortisol, make sure that you measure 4 times in a day to get a full diurnal pattern of the patient, and what's happening with the cortisol levels. So symptom association with salivary hormone levels, that are there any correlations or associations with symptoms, right? It has to correlate with symptoms. Otherwise, it makes no sense to do the testing if there is no relationship with the clinical symptoms. So, almost, as you can see here, almost 40,000 people's data shows here in this particular curve that this one is showing a relationship between estradiol and hot flashes. The estradiol level, when it is lowest, so this right here on x-axis is the estradiol levels, and on this y-axis you can see the average hot flash severity. So when you see that the estradiol levels are at lowest, hot flashes are maximum. And so there is a direct correlation between the estradiol levels. So as the woman enters menopause, the estradiol levels are lowest, hot flashes are at the highest. And that's the reason that when people start losing their, when women especially start losing their estradiol levels as they age, they start to see increased hot flashes. So as you increase the level of estradiol, as you, even with supplements, or well, this is the data from normal women. And if the levels are between 2 to 3 picograms per mil, which is considered as a kind of a normal physiological range, between 2 to 3 picograms per mil, the hot flashes, the severity of the hot flashes is at its lowest. And as you increase the dose, the hot flashes again start to increase. So you have to maintain a normal physiological range whenever you're treating your patients with any of these hormone supplements, no matter whether it's estradiol or progesterone or testosterone or anything else. I always recommend maintaining a normal physiology, right? Now, this one shows salivary testosterone in women, data from, again, more than 10,000 women. Now, the red line here shows the normal testosterone levels with age. Age is on the x-axis. So as you can see here, between the age of, say, 19 to 20, 24, the testosterone peaks and then starts to decline as you age. Now, the top line, the blue line, shows when the androgen excess. So androgen excess means when the levels are higher, the salivary testosterone levels are higher than normal, what you see is increased facial body hair as the testosterone level increase. And as it decreases, there is decrease in the facial hair or the body hair. Now, what happens when the testosterone levels are lower than the normal? The green line shows you what happens, what kind of symptoms do we see? There is an increase in vaginal dryness as the testosterone levels increase. So same thing, it declines. Those symptoms start to decline when the levels of the testosterone start to decline. So why I'm showing you all of these slides is just to make you feel comfortable that salivary testing is not fake, as some people still, conventional MDs still think that, oh, saliva, it's not good. Oh, saliva, it's not very helpful. I'm just used to testing blood. I will continue to use blood. I don't care what new research says. So that's the reason I'm sharing all of this data with you, that things have changed. Things are not the same that we had 10 years ago. So we need to clearly understand why saliva, why blood, why urine. And that's the idea of today's lecture. Dose response. So let's talk a little bit about the dosing. That when you're using the exogenous hormone therapy, what kind of doses that you should be looking at and why you should be looking at those doses. So this particular slide here shows you a kind of a patient data from almost 3,000 patients here, where you see oral estradiol seen in saliva. So these people, they took different doses of estradiol orally, and we tested their saliva. And what did we see? So here, as you can see on the x-axis, the daily dosage of estradiol is 0.2, 0.4, 0.6. And when you look at the y-axis, that shows you the saliva estradiol results with respect to the dose. So what did we see is that we could achieve a normal physiological premenopausal range even by using 0.1 to 0.2 milligram of estradiol, oral dose. So if you can achieve premenopausal range and normal physiological range with these low doses of the hormone, why do we have to use higher doses? I do not understand that. And that's the reason I invite all those experts who talk about using or dumping very, very high doses of hormones in the bodies. I still have to get any convincing data from all of those experts who are talking about using high doses of hormones. At least I'm not convinced. Why I'm not convinced? Because I have this data from thousands and thousands of people who I have tested in my lab. So how can somebody convince me that using high doses is good? Same thing as you can see here, topical estradiol. So the first one you saw was the oral estradiol. Now, what are the doses that you can or you should be using topically for topical estradiol? Same thing here, 0.1 to 0.2 milligram of daily dose of estradiol, topical application, creams or gels, is absolutely fine, is wonderful to achieve the physiological level. Then why go beyond that? As you can see here, if you go beyond that, look at where these numbers go. Look at these results. And interestingly, some of those people who like to talk about the high doses is because they have not tested in saliva. They have tested in the venous blood, where you do not see these high levels. And that's why it is extremely important what body fluid you're using to measure the hormones. And very interesting thing that I will share with you, and you're going to be fully convinced that why it is important to use saliva in some cases, not all, some cases, and why it is important to use blood in some cases. So again, same thing right here. This is the topical supplementation. When you measure this progesterone, 20 milligram daily doses, you can achieve this normal range, kind of a physiological range of topical of saliva progesterone 12 hours after the supplementation. So just to give you a glimpse of what happens, what kind of levels that you expect, 12 hours, 24 hours, like this one shows you levels in 24 hours after the supplementation for most of these patients. So this is a slide that I want you to pay attention to, that why I was saying that those people who talk about using high doses of these hormones, they probably have not seen this slide, or they probably have not seen this data, where you can clearly see as this particular patient used 30 milligram of topical progesterone, applied cream topically. And what we did was we measured the saliva and the venous blood, the serum from the same individual at the same time. We collected their sample, both samples, saliva and the venous blood at the same time. What did we see? Almost no hormone change, no change in the hormone level in serum. But when we tested in saliva, look at what their levels were. So high, so high. So let me ask you this question. If you were the one, you gave 30 milligram topical progesterone to your patient and you measured their hormones only in serum, what did you see here? Nothing. What will be your next step? Increase the dose, right? Because you did not see any changes in the hormone levels. So you will think that, okay, 30 milligram, maybe it doesn't work. Let me use 60. Let me use 100. What will you do? You will completely mess up that patient's physiology, because even at 30 milligram, the hormone levels that they had in their body, in saliva, bioavailable fraction available to the tissues, that was way higher than what was required. So we basically went totally in the wrong direction if we increase the dose to 60 or more than that. And sadly, I see some samples coming to us from some of the docs. And when I look at the reports and when I look at the hormone levels that those patients are using, that those docs are using for their patients, 80 milligram progesterone topical, 100 milligram progesterone, 120 milligram progesterone. And that's the reason we see such high levels of progesterone in their samples, that it's just mind-boggling. And I just feel so sad for those patients that they have those docs. Anyways, so serum versus saliva steroid hormone levels is extremely important to understand. Why? Because the correlations are very good when hormones are produced endogenously. Doesn't matter if you use serum or saliva when you're looking at the baseline, when you're looking at the hormones that are to measure the endogenous levels of hormones. But when you're supplementing, especially topical supplementation, you cannot be using the serum levels. You cannot be just using that testing in the venous blood. That's the reason you should be using saliva. And the topical hormones, the creams and gels, is so important concept when you're measuring these hormones. So topical application of all steroid hormones, estradiol, estriol, progesterone, testosterone, DHEA, cortisol, results in a marked increase in saliva hormone levels, but little change in serum hormone levels. That's what you saw in that slide that I showed you, the graph that I showed you. Let me show you another one. What we did with one of the volunteers in the lab, we gave her 15 milligrams of topical progesterone. And we collected her venous blood, capillary serum, the capillary blood, the DBS, the dried blood, and saliva from the same individual at the same time. What did we see? When you look at this black line, there was absolutely no change in the hormone levels. So nothing in the serum. We did not see any hormone in the serum. What did we see in the capillary blood? Significant increase, right? What did we see in saliva? Huge spike in the levels, in the hormone levels, because we are measuring the free bioavailable fraction of the hormone. What did we do? We learned something so important, that just by testing the right body fluid, we can make the perfect decision for the treatment plan. Now we know in this particular patient, even 15 milligram topical progesterone is way too high. So if we test saliva, we know that we have to reduce the dose in this patient rather than increasing the dose, right? That's why it's so important. So this DBS that I was explaining to you, for some of those who are not familiar with what is dried blood spot testing, although I think most of you might have come across this type of testing now, which is now widely available everywhere, because we get samples from pretty much every part of this planet, that where you can just prick your finger, collect a few drops of blood on this card that you can see, and you can just put it in the envelope and mail it to the lab. It's so simple. What are the good points? It's convenient, simple collection procedure, because finger prick is way more convenient than the venous blood draw. Diabetic patients, they prick their fingers all the time, many times actually during the day. More latitude in collection timing than serum. So nighttime sampling is possible, especially for cortisol and insulin. Dried serum analytes are very stable. Like liquid blood is not stable, but dried blood, all of these hormones are extremely stable for almost 30 days. So absolutely no problem in shipping, storing, sampling, all of these good points. So wider range of analytes can be tested, and results and ranges are actually equivalent to serum plasma for endogenously produced hormones. Again, you have to be careful when you're measuring the basal levels, endogenous levels, then it's okay to use those ranges or the method of testing. But especially when you're supplementing with hormones, that's when you have to be very smart, very careful about what methods you're using. So in the capillary blood collection more accurately reflects tissue uptake of exogenously used hormones than the serum plasma. Why blood spot and not saliva? Again, it's important to understand, okay, when to use blood spot, the capillary blood, and not saliva. Able to test peptide hormones, because let's say, for example, you want to do thyroid hormones, the full thyroid panel, FT3, FT4, TSH, TPO antibodies, reverse T3. You cannot measure those in saliva because of the reason that the concentrations are so low in saliva that we don't have a sensitive technology to measure. Actually, no lab has the technology yet to measure these peptide hormones in saliva. So that's where the capillary blood comes very handy. Most accurate test for measuring steroid hormone levels in individuals supplementing with sublingual or troche steroid hormones. Because in saliva, if you're measuring after troche or sublingual or oral supplementation, then there will be overestimation in the levels. So it's always a good idea to use the capillary blood rather than saliva. Allows for measurement of bioavailable fraction of steroid in blood when combined with measurement of blood binding protein. So in case when you're not able to measure in saliva and you have to measure in capillary blood and you have to get a free fraction of the hormone, in that case, you can measure SHBG along with any hormone that you're measuring, let's say testosterone. So with testosterone, when you're measuring in blood, even with the capillary blood, you're measuring total hormone. And to find out how much is the free and how much is the bound, you have to measure SHBG at the same time so that you can calculate and find out how much is the bound and the unbound fraction and what correlates better with the clinical symptoms. So, well, I don't want to bore you with these slides. These are just to show, because I get asked this question sometimes, that how do you know that liquid blood is, or the dried blood is okay to use, is as good as the liquid blood? So then I show them this slide that there is a beautiful correlation between the liquid blood and the dried blood when you're measuring these hormones. So this is a particular slide for progesterone, where the levels in the liquid blood, as you can see here, this is the blood spot and this is the serum, the liquid serum. So there is a beautiful correlation between these levels. So nobody can question me or nobody can challenge me that there is difference between the levels in dried blood versus the liquid blood. So there are a few more correlations. Let's not go there. How about the sublingual progesterone? So this is some data on the sublingual progesterone dose, that what kind of dosing that you should be using to expect what kind of levels. As you can see here, 20, 40, 60, 80 milligram of sublingual progesterone dose shows these levels. So red one is after 8 hours, the blue is after 12 hours, and the green is after 24 hours. So these are the kind of levels that you should expect when you're using these kinds of doses. Venous versus capillary blood progesterone levels following topical progesterone use. Well, you saw some data earlier, but just to give you some information in terms of numbers so that in your mind when you're processing all of this information, you have an idea of what kind of numbers to expect when you're using these different body fluids. So this one particular patient using 20 milligram of topical progesterone. And as you can see here, 3 different types of body fluids were taken from the same patient: serum, blood spot, and saliva. So what did we see? Progesterone levels. When we tested serum, we saw 1.9 nanograms per ml, which is kind of lower than the normal luteal range, which is 3 to 25 nanograms per ml. When we tested blood spot, the capillary blood of the same individual, what did we find? 24.6 nanograms. And the normal range is 3.3 to 22.5. So what did we see? Did you see the difference? If we were testing only serum, we thought that the levels were lower than the normal luteal range. But when we tested, if we tested blood spot, we concluded that the levels were higher than the normal luteal range. Totally opposite, totally reversed interpretation. And look at what happened when we tested in saliva. And if we tested in saliva, look at how high it is beyond the normal range. 75 to 350 picograms per ml is supposed to be the normal range. What did we get? 1,291 picograms per ml, which is way higher. So what does that tell us? Which one is the best way to test in this particular patient? Blood spot or saliva? Absolutely no way serum should be used in this case, right? So what is this conclusion here? Capillary blood level of progesterone is 10 times in serum, which is so that serum grossly underestimates tissue uptake of progesterone delivered topically. What does that mean? Please do not use venous blood, venous serum to test this patient if you gave this patient 20 milligram of topical progesterone or any dose of topical progesterone. That's the lesson here. Are you guys still awake?
We're here though.
Yes.
Okay, good. At least one of you is still there.
I think we're all here.
Okay, good. I have to make sure.
Yes.
I'm here.
Like, as I said, if I'm on this podium, then I can see my audience and I can see who is awake and who is not awake. All right, so some more interesting stuff here that I have to share. How much time do we have? I think another 10, 15 minutes?
Yes, Doc. It might longer than that since we already have several questions, but yes.
Okay, you
Take
already
your time,
have
that's
some
okay.
questions. I can stop and answer your questions.
No,
because
I don't know. I don't know. It depends on you. Which
okay,
one do you?
well, I think let me quickly cover some of the pending slides that I have,
Yes.
some of the data that I have quickly, and then take some questions. So basically, this slide also shows the same thing that I shared with you earlier. This is, earlier I showed you progesterone after topical administration when we measured in saliva, and you saw what happened. And here, this is measuring in blood spot. So same thing as you can see here, the daily progesterone dose of approximately 20 milligram of topical progesterone is good enough to achieve optimal luteal range of progesterone in the capillary blood. So that should tell you that what kind of dose is good to use, why it is not good to go beyond these numbers. Like, as I said, I see people using 80 milligram or 100 milligram, So guess what? Their levels are way, way, way beyond their optimal luteal range. And that's not what we should be doing to our patients. Testosterone, same thing. Look at the dose which is good enough. 5 milligram, 10 milligrams. Lower doses are absolutely good enough to achieve the normal physiological range. And this is the reason, if you trust this data, and please do, because this is a beautiful piece of data from thousands and thousands of people that we have tested in the lab. And we are fully convinced that it's absolutely not okay to use higher doses of these hormones. And because it's always a good idea to stay within the normal physiological ranges and not go beyond anything else. So why is this so important to understand? Need to have a hormone test that accurately reflects how much hormone is being taken up by tissue, not how much is circulating in the venous blood. Always remember this. Please do not focus on what is circulating in the blood. Please try to find out how much is actually available to the tissues for their consumption, for the normal physiological functions. So with topically delivered hormones, venipuncture, serum, and urine grossly underestimate, almost 10 times underestimate tissue uptake of hormone, and underestimating tissue uptake based on venous serum results often leads to overdosing. And that part I already explained to you, that if you were measuring only the venous blood after topical administration of the hormone, your decision will always result in overdosing the patient. So please be careful on that. Prevents overdosing of patients with topically delivered hormones and allows for a more physiological delivery of hormones to target tissues. Same thing over and over. Please keep that in mind. And so, as I said, this slide is the same slide that I started with, and you have to pay really good attention when you're using all these different body fluids. So keep this slide as a Bible in front of you whenever you're treating patients, supplementing them with, and deciding on whether to use saliva or blood or urine or whatever way you want to treat your patients. That is the reason it is extremely, extremely important to choose the right body fluid. So I will stop right here and open for any questions if you're all still awake.
You're still awake though. We actually already have several questions though. Dr. Kapur?
Yes, go ahead.
Yes, okay. So the first question is from Dr. Sanki Lee. Doctor, does this test protocol is for baseline or for treatment follow-up?
Okay, so that's what I want you to pay attention to, that as I shared with in that summary slide, whenever you're measuring the baseline, it does not matter whether you use the serum or the saliva or the blood spot or the urine. It's only when you're measuring after supplementation of the hormone, that's when you have to make the right decision. And then in case you want to use baseline cortisol levels, then it's always a good idea to use saliva, because saliva has been established as a gold standard for measuring cortisol. Number one, it is testing, or it is providing you the free form of the hormone, which is a bioavailable fraction. Number two, it is giving you an easy option for your patients to collect their sample without pain 4 times a day. And you should always be measuring cortisol 4 times a day, not just the morning cortisol. So the simple answer to that question is that for baseline levels, for endogenous levels, you can use any method, but for supplementing hormones, you should be carefully deciding what exactly to use.
Dr. Sankili?
Yes. Thank you.
Okay.
Does that answer your question?
Yeah, Doctor. Thank you. Yes.
Okay, perfect.
Okay, thank you, Doc. Our next questions come from Dr. Angi. I'm asking about DHEA in children around 10 to 15. How much is the normal range? And is it the DHEA correlated with development of the children, not correlated with their immune, or different with adult?
Okay, so we do not have pediatric ranges for DHEA because we don't test the samples from children here. But the reason that you have to kind of individualize your treatment for children is because in children, their hormone levels are still like kind of building up. So they are fluctuating until they hit puberty. Now, especially in puberty from 13, in teens, from 13 to let's say about 19 years, 20 years of age, 21 years of age, their DHEA, their cortisol, their estradiol, testosterone, they're all over the place. There is no pattern as we see in adults. We don't see that kind of a pattern in children. Now, interestingly, in younger adults, what we have seen from data from our lab, we see very high levels of DHEA as compared to adults. And that's when now we are thinking of kind of separating out the DHEA ranges for those younger adults where we see high DHEA, because it looks like in that age group, their DHEA is normally high. Earlier, we used to think that it's a high DHEA, but now we have tested almost like 20,000 patients in the lab, and we found that younger adults have higher DHEA levels. Now in kids, little kids, it's difficult to say what is the normal range of DHEA because of the reason that it fluctuates, the levels fluctuate. And you have to make individualized decisions, especially in kids. It's kind of tricky. Did you have any, like a specific question? Did
Yes,
you have any
actually,
specific patient?
yes, she added with a case though. I have patients 13 years old with DHEA is 60, and another one is 15 years old with DHEA is 140. Both patients are detected in days the 7th after fever suspected with COVID-19. So I think that, yeah, this is why she asked about immunity.
Right. Well, with DHEA, like as I was sharing with you during my talk, that DHEA, I have not seen much of data with COVID, but there has been a lot of data on cortisol. Now, it is possible that by supplementing DHEA to these patients who are seeing that shift in the cortisol DHEA ratio, it might help them. It might help them. I'm not saying that it will because I don't have enough data to support that claim. But as we have known and seen in existing data that we have, is that it's always important to keep the cortisol DHEA ratio to where DHEA is higher, of course, than the cortisol, because DHEA is the anabolic and cortisol is the catabolic hormone. Now, in terms of COVID patients, they are showing extremely high cortisol levels. Now, what does that mean? It shifts that ratio between DHEA and cortisol. Now, again, there is no specific ratio that we know for kids, but it's always it might be helpful because DHEA, you're not going to kill anybody unless you give them extremely high doses of DHEA, right? as long as you stay less than 50 milligram for these kids. Well, even 50 is too high for kids. As long as you stay under 30, 25, 30 milligram, I think you should be fine. It might help. But again, it's not just the DHEA that might be helpful in these kids. It's always a good idea to supplement them with vitamin D, vitamin C, as there has been an extensive data on vitamin D, especially with COVID. So that might be something to keep in mind when you're looking at these patients.
Thank you,
Again,
Doc.
COVID has confused everybody
Yes.
until we gather enough data where we can feel comfortable saying that, okay, this dosing is important, or do this dosing for this particular patient. I think we are still a long ways to go where we can feel comfortable making those statements.
Yes. Okay. So the next questions, though, can I move on to the next
Yeah,
question?
go ahead.
Yeah, okay. From Dr. Sanjay Lee. Doctor, please feel free to reject these questions. So far, how many patients do you have prescribed with BHRT? And if you already have them, would you mind sharing some of your complicated cases?
So,
And
yeah, go ahead. Complete your
and
question.
how to keep a good ratio of DHEA and cortisol?
Okay, so from the lab perspective, we don't prescribe any BHRT because Iometrics is a lab. We only test samples. And so, no, we don't recommend, well, not recommend, we do recommend, but we don't prescribe from the lab. You can just send us samples and we can test that, and we can give you the right numbers. And based on that right numbers, we can recommend what kind of BHRT to pursue, but we don't prescribe any BHRT. So I wish I could share that kind of data with you. But yes, we do know, we do work with a lot of BHRT docs that I will be more than happy to connect you with, who can help you with that kind of information. And as far as your question about DHEA and cortisol, again, as I was sharing earlier, that you have to make sure that your DHEA levels, because DHEA is the anabolic hormone and cortisol is the catabolic hormone, you have to make sure that DHEA dominates cortisol levels and dominates to a level where it does not become toxic. So for men, it is recommended to use 50 milligrams of DHEA, and women can use 100 milligrams of DHEA, daily dose of this, to kind of maintain the normal physiological levels. Again, see, this is something that I always tell everybody, that don't just pick up a hormone and throw it inside your body unless you have tested your sample properly. So you have to make sure that you test before you recommend or prescribe any hormones or any kind of dose to your patients. So, and of course, other than the supplements, hormone supplements, there are many, many other ways where the way that you can maintain these hormone ratios in balance. For example, you can use many, many different kinds of adaptogens. Now, adaptogens means ashwagandha, bacopa, rhodiola, those kinds of adaptogens. Now, why those are called adaptogens? Because if your hormones are high, those adaptogens can bring them down. And if your hormones is low, then those adaptogens, use of those adaptogens can raise the hormone levels. So again, the conclusion that I always give in my talks is that try to stay as close as possible to the normal physiological levels, and don't try to do any supplementation in excess. Does that help you? Does that answer your question?
Dr. Sankili?
Yes, the network is interrupted. I could not hear you because interrupted network.
Oh, I'm so sorry. Are you recording this
from my
lecture?
side? I think that the network from my side is interrupted, so I missed part of your explanation.
Oh, I'm so sorry.
Okay, that's okay, Dr. Sankili. We do record this, and you will all get the recording, so you can watch it again. So Dr. Kapur, should we proceed, or do you want to explain a little bit more?
Yeah, go ahead if you have any more questions.
We do have one more question, and I think this will be our last question for today's session. Doctor, do you have experience with patients with all sex hormone are low, and also low ACTH and low cortisol level and low thyroid? And if you do have, if you treat, which I understand that you don't treat the patients, could you tell me the detail about the successful patients?
Right. So yes, we do see many patients where we see all the hormones are low, and most of them, when we see all of their hormones are low, that ends up being correlated with their low cortisol levels. See, one thing you have to understand is that all these hormones, they work in conjunction with each other. Now, all the steroid hormones, all the thyroid hormones, adrenal hormones, they all work together. It's kind of a triangle where all these systems are connected with each other. It's nothing like one size fits all, or if you fix one hormone, then everything will be fixed. Or you can only focus on fixing one of these systems or one of these hormones. So you have to go step by step and kind of approach it with a holistic mind. You have to consider that all of these hormones are like a spider web. If you pull one side of the spider web, the whole web is messed up. And that's the reason we have seen that in some patients, if their adrenals are messed up, all the other hormones are messed up. If their thyroids are, if the thyroids have some problem, you will always see their estradiol and progesterone going out of balance. You will always see their cortisol levels either high or low. Most of the time it's low. You will see their DHEA levels getting affected. So, and this is the reason, because all of these hormones, they are working in conjunction with each other. So it's always a good idea to, what they say, what is recommended is fix the adrenals first. Fix the adrenals, most of the times, most of the other problems are fixed. If you still see a problem in thyroids after you have fixed the adrenals, then of course you can approach the thyroids. But it's always a good idea to start with adrenals, fix their cortisol, fix their DHEA and androgens. And most of the time you will see that other hormones will fall in place.
Okay, so Dr. Anggi,
does that answer your question?
Dr. Anggi, could you put on your microphone? Or you could write on the chat.
Yes, thank you so much, doctor. A great explanation. Thank you so much.
Thank you, Dr. Anggi.
Thank
Okay.
you.
Doctor, could I ask one more question?
Yes, Dr. Sankili.
Okay, yeah. So, doctor, you mentioned like we should fix adrenal gland function first. How about the thyroid? So for the patient with clinical hypothyroidism. So we still switch adrenal gland first, or we start with the supplementation of thyroid hormone first?
Well, if you already know that there is any problem with the thyroids, then I would not worry about adrenals. It's only when you're not aware of the patient's condition. If you already know that the patient has hypothyroidism, then I would not worry about adrenal first. Then in that case, I would directly fix the thyroids, the hypothyroidism. And then later on, well, you could always see or you could always test how their cortisol levels are or how their estrogen progesterone ratio is. But it's always a good idea in known patient, especially if you know that there is a hypothyroid case, then I would rather focus on that first.
Thank you, Doctor. Thank you.
Okay, so is there any other questions? Doctors? Okay, if there is no other questions, then I think we can wrap up here, Doc.
Excellent. Well,
Yes,
thank you very,
thank
very
you
much.
so much. But please don't go just yet because we want to take pictures with all of you as usual. We take pictures with our speakers, and we do. This is our last sessions for our hormone webinar series, and we would like to thank you on behalf of Dr. Sarah and the others, and Ms. Ian and also Dr. Rani. I would like to say thank you for all of you to joining our webinars and to our events for this 2020. And we will take a break because we will be heading to a new year. But in 2021, we will be back with another topic, which is heart health and health coach. So stay tuned for our next webinar in 2021. In the meantime, all the slides and recording, we will try to email you as soon as we have everything. So Dr. Kapur, I would also like to ask for these slides. Could you email us?
Sure, absolutely.
Yes, thank you very much, Doc. And then, yes, so I think we can take a picture right now. Miss Ian?
Yeah, siap.
Okay, to all doctors, to all college, please open up your videos. We are going to take pictures.
Oke, boleh screen-nya juga di stop dulu, Dok.
Oh yes, Dr. Kapur, can you stop the screen sharing, Doc?
Okay, yes.
Thank you.
Ya, yang lainnya. Yang lainnya boleh dibuka. Ya. Oke. Lagi, yang lainnya boleh dibuka videonya. Ya. Oke, Dr. Lisa.
Okay, thank you so much. And I think that's it.
All
I
right,
will
thank
see you in next event probably, Doctor.
Thank you, absolutely. Thank you.
Thank you.
Thank you so much, Doctor.
Terima kasih banyak.
Thank you, Dr. Lisa. Thank you, Dr. Lisa semuanya.
Thank you all.
Thank you.
Thank you to all college too.
Sampai ketemu.
Okay. Bye-bye.
See you all the next event.
In our
Thank you.
next event. Bye.
Okay, bye.